We welcome Professor Graham Martin, Director of Research, the Healthcare Improvement Studies Institute at the University of Cambridge, who's going to speak to us about learning from the past to improve openness in the present. Over to you, Graham.
Thank you, Ron. Privileged to be here. Thank you for the invitation. So what I'm going to be talking about this morning is findings from a programme of research that we undertook over the period following the Francis inquiry, particularly focused on the variety of policies that followed Francis and their impact on culture and behaviour in NHS organisations. I'm going to start by giving you an overview of the findings of the programme as a whole, but what I'd like to focus on in particular is this question of what it takes to start to instill a culture of openness that has a chance of sticking, that has a chance of lasting through time. So I'm going to focus in particular on four areas of Thank you. Sorry, slight lag here in the slide transitions. Four areas, four conditions of success, features of NHS organisations we looked at that seem to be associated with a chance of making that culture, changing culture around openness last. More briefly, I'm going to be talking about four persistent challenges that were faced by all the organisations we looked at. I'm planning to speak for about 25 to 30 minutes, so there should be time for discussion and questions at the end. So the background to this really comes from the Francis report, which of course needs little introduction, getting on for 10 years now since the publication of Robert Francis's public inquiry into what happens at Mid Staffordshire, and likewise the challenges in quality, safety and patient outcomes and culture at Stafford need little introduction. Now, of course, famously, Francis made 290 recommendations about what needs to change both at Stafford and beyond in terms of improving quality, safety and openness. There was no single failure and no single response that Francis identified. But I think it's fair to say that he saw culture as central to both the problems and the potential of solutions. So he highlighted culture there, as we see in terms of the problem. Number one, in terms of the causes there, a culture focused on doing the system's business and not that of the patients. And number one, in terms of the aims of those 290 recommendations, is to foster a common culture of all in the service putting the patient first. And I think what we can see there is this notion that key to many of the problems at Stafford and perhaps problems that manifest elsewhere in the system is this closed culture. The notion that openness is a way of changing behaviour, changing culture for the long time. And many of the measures that Francis suggested were about that. But of course, and I don't need to tell people who are watching this, make this point to these people, culture is something that's very difficult to change. It's not something that can be acted on directly. In many ways, it's more about what an organisation is than something that an organisation has or even what it does. So how do you go about changing culture around openness, for example? Well, the government's answer to that was in terms of a wide range of policies, some of which arose directly from Francis, some of which arose over the following years, for example, following similar issues and similar recommendations at Morecambe Bay and elsewhere. A whole range of different interventions, policy interventions that were designed in some ways to improve openness. They had their own immediate objectives, for example, around disclosure in terms of the duty of candour, or around increasing the opportunities for people to speak up about concerns through the Freedom to Speak Up programme. But if you look at the kind of the detailed thinking behind those policies, they're also about something bigger, about the potential for an aggregate impact on culture and behaviour around openness in the NHS. And just as a very quick straw poll, I'd be very interested to hear which of these have been most impactful in your organisations. So if we could open that poll, it should be coming up on the screen now. As you can see, 8 options here. These aren't all of the policies that came up, and I think you should be able to vote for more than one. You can vote for less than one as well if you don't think any of them have been impactful. But let's just have a look in a minute and see which of these seem to be the most impactful for people here. Okay, I'm not sure if many people have had a chance to vote yet, but let's give it just a minute, half a minute more perhaps. Okay, let's see what the results came up with. Okay, so yeah, changes to the CQC's regime in particular highlighted, along with freedom to speak up guardians. We as part of the research that I'll be discussing in a minute, we ran similar questions as part of a survey which included board members. And the results not dissimilar. Interestingly, statutory duty of candour was seen as much more impactful by that cohort. So it's interesting to see that that's one of the less ones here. But clearly, the CQC regime and freedom to speak up seen as quite impactful by this particular group of people. So those interventions, among others, were the focus of our research over the period 2017 to 2020. We were asked by the Department of Social Care's Health and Social Care's policy research programme to look at these interventions as a whole. So not looking at the direct impact of, for example, freedom to speak up on voice or of duty of candour on disclosure, but rather the impact in the round of these interventions in terms of the possibility that they might be leading to a changing culture around openness, candour and learning. This was a mixed methods study. I'll be talking very briefly about the first things there. Unfortunately, those highlights have just been displaced, but they should be over the first 3 bullet points. I'll be talking about giving you an overview of the findings of the study as a whole. I will then, and this highlight should be on the last of those, those bullet points, be spending most of my time talking about the case study work that we did in 6 NHS organisations, 3 acute trusts, 2 mental health community health service trusts and 1 ambulance trust. Quite detailed work involving speaking to patients, staff, relatives, frontline staff and senior staff in those organisations about how these initiatives were playing out in practice. And that's what's given rise to the 4 necessary conditions that we highlight for changing culture around openness and the 4 persistent challenges that I'll be talking to as well. So that's the main focus of the presentation. Before I get to that though, let me just give you a brief overview of the findings of the whole study. So one part of this which you can find in the paper which is there, the QR code should take you to it. It's also available in the resources section of the conference website. One part of this work, led by colleagues in Sheffield, focused on routine staff surveys and patient and service user surveys that are done every year. So the NHS staff survey, the NHS acute inpatient survey, and the equivalent survey for mental health community mental health service users, essentially looking to see if there was a change in the trend before and after the publication of Francis in relation to key questions which we saw as relating to openness, such as things around ability to speak up in teams, the degree to which senior staff are seen as being open to learning around safety and so on. What we found in terms of that longitudinal analysis through time was some quite promising looking findings in relation to NHS staff. So there were significant trends towards improvement on those key indicators of openness that we looked at. And that trend sort of accelerated over time. If you looked at the sort of an upward shift in the trend from before Francis to after Francis. Very similar findings in relation to acute inpatients for equivalent questions. For community mental health service users, a more equivocal position. So less consistent trends, less of an upwards direction in terms of the positivity of those answers, and some signs actually of stagnation or even reversal in terms of those improvements over time after the publication of Francis. Interesting finding, particularly given so much recent emphasis on parity of esteem for mental health. In terms of explaining that high-level finding, one thing that came to light from part of the research that we did, focusing on interviews with senior stakeholders in and around the NHS, so people like you, people in regulatory bodies, policymakers, medical directors and the like. Points that we heard consistently from them was a sense that many of the interventions that had followed from Francis were built around a model of service delivery that was focused on acute care. The notion of an NHS organisation, an NHS hospital that has is relatively coherent, perhaps single site or a few sites, that comes into contact with patients in a relatively episodic way. So people with acute conditions, of course, often with complications and multimorbidities, but in hospital for a specific service and out of it again at the end, which has rather different implications for the kinds of problems that might arise, the kinds of concerns that might arise from NHS organisations that are different, including, for example, mental health care trusts, which typically, not always, but typically are perhaps more diffuse geographically, perhaps more diffuse culturally, often amalgamations of different organisations, you know, for example, following the splitting of commissioning and providing parts of PCTs in the 2000s, many of which were incorporated into mental health organisations. The kinds of issues that patients have that they deal with are quite different as well, potentially less episodic, potentially more chronic and ongoing, and often involving many different teams within an organisation and beyond that organisation. So very different organisational characteristics and very different kinds of issues that might arise that demand a response in terms of openness. And even within those acute organisations, many of the people we spoke to said, you know, in the bigger organisations in particular, multi-site, perhaps the result of mergers and the like, implementation of these policies was really challenging. Getting it out from the core of the hospital to all the different corners was challenging, and many different parts of organisations could often cause different kinds of concerns, and, you know, ensuring that there was a consistent cultural change across such a big variegated organisation was a challenge. One other key point from that part of the research was really the persistence of memory, if you like. The fact that things that had happened a long time ago stayed in the organisational memory for a long time afterwards. So if someone had tried to embrace openness and essentially been punished for it, had been castigated by their colleagues, punished by senior managers and the like, then regardless of what had happened since, that remained in the organisational memory. And it's not surprising at all. Trust is so easily damaged. And why then should people believe that just because of the Francis report, just because of many good organisational words, they're going to be treated any differently now? So issues from a long time ago could continue to cast a long shadow over the future. And I think that drills home the point that changes of this kind take time, not just to implement, but to ensure that everyone genuinely feels that they have the ability, that they won't be treated unfairly if they raise concerns, if they look to change the quality of care. So those are very high level findings from the study as a whole. As I say, what I want to focus on for the remainder of this presentation is, first of all, 4 conditions for success that emerged particularly from our case studies of 6 NHS organisations, 3 acute, 2 community mental health, 1 ambulance trust. And what we found in those organisations was that what seemed to differentiate the ones where these initiatives were sticking from the ones where perhaps there was a lot of activity, but it didn't seem to be having an impact on the views and experiences of frontline staff and patients and carers, were a number of things, but I'm trying to distill them into these 4 messages here. And I'm going to give you these 4 apparent conditions for success without suggesting for a moment that they guarantee success, and without being able to say with certainty that success was really sticking here. But I think perhaps characterising them as necessary conditions, if not sufficient conditions, is about right. So the first one I want to speak to is the need for functional administrative systems, as we've characterised it. Now, bureaucracy is not fashionable, but good quality administration is, of course, essential. And I suspect, again, I'm preaching to the converted on this point. Leadership, of course, and empowerment and the like are vital, but having really good organisational systems that function effectively is critical, both to sort of feed the beast in terms of monitoring and compliance, because these are initiatives that require a great deal of documentation and timelines and deadlines, and feeding those back to regulatory organisations, but also to make sure that processes that are quite deceptively complex in a lot of cases are undertaken effectively. So if you take, for example, a duty of candor disclosure, that involves lots of people at different times. It involves different timelines and deadlines. It requires notifications by certain dates. It requires letters, documentation. It becomes even more complicated, of course, if it spawns incident investigations as well. Similarly, for freedom to speak up guardians, there's a huge bureaucratic caseload burden there in terms of managing different cases to conclusion, pushing people forward, making sure that responses are got from different parts of the system, keeping informed the person who has raised a concern initially. Well-functioning administrative systems were absolutely crucial to ensuring that these were delivered effectively and sensitively. And I'll give you a little contrast here between two organisations, the one on the left where they really seem to have this nailed. So senior colleagues in this organisation could talk at length about all the processes they put in place to essentially manage concerns as they arose, to timelines, ensuring that they were monitored at a senior level, action points went out, a very carefully put together IT system that coordinated all this, and essentially not just processing concerns that arose and learning from investigations and the like, but also ensuring that they went to the right parts of the organisation. Contrast that perhaps with the organisation on the right, someone in a similarly senior position who, as they say at the start, isn't really quite sure how well their system works. And if you look at that description there, then it's a lot vaguer in terms of how this information is cascaded from the top to the bottom, whether it actually reaches people. Every local clinical team has 1,000 meetings, and eventually perhaps it filters down so that ground floor staff will have it. Very different descriptions of how well functioning these processes were working, and they manifested as well in the experiences of other people that we spoke to. Another facet to that point about functioning administrative systems is really about tying up different sources of intelligence. I think this probably relates to the session that you had on Tuesday, if you attended that, on problem sensing. People in organisations that seem to have this better worked out were very keen on triangulating, bringing together different sources of information. For example, from trainee surveys, learning from death process, freedom to speak up, duty of candour, investigations, etc. Coordinating between those, picking up noise in the system, identifying where problems seem to be occurring, and investigating accordingly. The second condition for success that I'd like to highlight is kind of a counterpoint to the first in some ways. Need for flexibility and sensitivity in implementation. So, of course, functional administration was a necessary condition. But at times, the sheer bureaucratic burden, particularly in terms of displaying compliance and ensuring that things were documented in the right way, could be seen as getting in the way of doing this in a sincere and sensitive way that would meet the expectations of people who, patients and staff would raise concern, people who had experienced harm in the right way. So there was a challenge in terms of balancing the heavy monitoring and accountability framework for the initiatives with the expectations for, good, sincere, sensitive handling of the issues. And this was something that was very difficult for staff to face, particularly when there were concerns about liability and indemnity for people who, for example, were involved in a duty of candor disclosure. The organisations that responded to this well, just going to skip through these ones, excuse me. The organisations that responded to this well had quite sophisticated, clever, creative ways of handling this. And this is just to give one example in relation to duty of candour, whereby an organisation had developed these sort of template letters that provided a steer to people involved in a disclosure without telling them what to write or risking starting to reduce it to bureaucratese that would frankly do very little to reconcile and might even end up leaving people feeling that they had had insult added to literal injury. So talking about, providing them with a starting point, a template, give them the gist of what they want to do, but allow them also a little bit of space to communicate what had really happened in a sensitive way. And perhaps meet the needs and expectations of people who had been on the wrong end of harm that arose in the course of their care. Similarly, freedom to speak up guardians, very helpful to give them a little bit of leeway in what they could do. And sometimes they had to bend the rules because, with challenges around confidentiality, around due process and so on, they had to be very careful about what they fed back to people who had raised concerns. And for someone who's raised concerns, often that looks like obfuscation. Sometimes it looks like their concerns are disappearing into a vortex. So doing just a little bit more informally to accompany the formal process was absolutely vital in reassuring people that these concerns were being taken seriously and were leading to change. Condition of success number 4 is around integration into organisational mission. And what I mean here is that it was really palpable to us, and it was really palpable to frontline staff, where an organisation was taking things seriously and where, in contrast, an organisation was just grafting new initiatives onto what was already there. So where these efforts were a bolt-on, it was crudely obvious to people at the sharp end that the organisation wasn't taking them seriously. And you see a prompt like that, you respond accordingly. I'll illustrate this with a couple of contrasting experiences of freedom to speak up guardians. Trust B here, the Guardian was very well supported in terms of both dedicated sessions to do their job and wider support in terms of getting to the right place in the organisation. So they talk about, targeting each individual directorate, getting to meet the director, getting into routine team meetings, just showing their face. And I think that's a particularly telling line there. It's about seeing a face rather than just a brand, so that people, who have concerns feel confident in raising them with someone. It's not just another bureaucratic mechanism, it's someone who might be trusted, because these are, of course, high stakes decisions for people who raise concerns. And, at the bottom of that, making it clear that Francis wasn't just about Stafford. Francis is also about us. And if we respond to these things well, then we've got a better chance of improving quality and ensuring openness. Contrast that with the experience of the Freedom to Speak Up Guardian in Trust C here, who in contrast had much less time funded. Of course, all organisations have to fund this from their own pots. There was no dedicated or ring-fenced funding for Freedom to Speak Up Guardian. So there are compromises to be made here for organisations. This organisation had chosen to spend much less time and effort on its Freedom to Speak Up Guardian. You can see the result there. They were little more than a screensaver. They were a photo on the wall, but even that was only because the CQC had come along and suggested that the profile be raised. And the consequence, they only get 5 or 6 approaches in a quarter. And of course, we know from the National Guardian's Office that there's a huge variety of numbers of cases for Freedom to Speak Up Guardians across apparently similar organisations. And I think that's reflected in part in the degree to which this kind of function is incorporated into routine business or not. And of course, just because a Freedom to Speak Up Guardian, well, I think if you assume that because a Freedom to Speak Up Guardian is receiving few approaches is because there isn't anything to worry about, then I think you're in a dangerous situation. So much more investment in these kinds of roles. And similarly, a lot of work in some organisations to try to mainstream openness, to try to take it out of those exceptional high stakes situations, such as when something has gone wrong, a patient has been harmed, duty of candour kicks in and all the rest of it, and bring it into the routine activity. For example, through behavioural standards frameworks. Lots of organisations had these, but some of them were able to talk to us much more about the way they'd kind of made these useful and day-to-day, a kind of resource that they wanted staff to use in interacting with each other. So integrating them into inductions, making these standards something that people try to refer to on a day-to-day basis. It takes a long, long time, of course. But again, it's about trying to make this openness routine, day-to-day business, trying to de-exceptionalise it, if you like. Finally, and perhaps underpinning the other 3 conditions of success, is around making this a long-term part of the organisational mission. So these, again, are complicated, knotty problems that take time to work out. And that means long-term investment. It also means not reducing these activities to time-limited projects that are subject to 6-month plans, deliverables, put them to one side. Of course, good quality project management is absolutely vital, and having deliverables, outcomes, theories of change and all the rest of it is really, really crucial to making them happen, but they can't be reduced to that. They have to be an ongoing part of the organisational mission, not a time-limited project, and reducing them to time-limited projects is problematic. In contrast, trying to have a situation where it's organic, where you respond and learn from what is already happening and build on it and move forward is the way to go. So those are 4 arguable conditions for change. What do they tell us in terms of the state of the NHS in the 9 or so years since the public inquiry from Francis was published? Well, I think the first thing to say is that from our research, at least, it's very difficult to say how lasting these changes will be. A lot of it took place at a point in time around 2018, 2019, 2020. We have the longitudinal analysis, which suggests some cause for optimism and some cause for concern, particularly when you compare acute and mental health environments. But we can't necessarily say that these things are lasting, at least from our research. What we can say, and again, I suspect this will be no surprise to this audience, is that top-down policy implementation in and of itself will achieve very little. It's not a matter of putting these policies into place leaving them and expecting them to change. Rather, it's about how they're done and how they're linked up to one another that's vital. Even within NHS organisations, and this applies even to those case study organisations that seem to be doing really well, there were parts of the organisation where there were still concerns. And as I've said already, that kind of varied organisational topography, different buildings, different people, different histories, could have a big impact on the extent to which these positive policies could be spread and made to be impactful. Despite those caveats, I think what we can say is that we have signs of the kinds of things that can make a difference. Certainly, again, from the case study organisations we looked at, a lot of them had been doing this for a long time, and a lot of the work predated Francis, often owing to incidents, concerns, even scandals that had happened, before, either at the same time as or even before Stafford was a problem. So these were long-term efforts onto which the specific initiatives from a national level had been added and made to be complementary. So it's a long-term effort. And mainstreaming that activity and maintaining that focus through time does seem absolutely vital to its sustainability. In some ways stating the obvious, but I suppose it's just to emphasise the point that these are not initiatives that can be ticked off and put to bed. They have to be built on and developed through time. So perhaps unwisely, I'm finishing on perhaps the more negative note. So 4 characteristics that are associated with positive change, 4 persistent challenges that affected all the organisations we looked at, no matter how well they were doing. I won't dwell on these. I'm going to say much less about them, but I want to get them in because I think they're food for thought in terms of how you deal with them. The first one is around the NHS's reliance on goodwill and discretionary effort. I noted there was a session on Monday about supporting staff during and beyond the COVID-19 pandemic. And of course, staff wellbeing in the NHS, challenges of impending retirements, of recruitment, of retention are not new. But it's certainly notable with these openness initiatives that they rely to a very great extent on goodwill, extra hours, going above and beyond what is usually expected of people. And I think there are questions about how sustainable that is. Wellbeing initiatives are important. Workforce investment, of course, is important. Not all of these problems are tractable to local action, but they certainly need to be thought about and responded to. The second one is around what we call the limits to an ethos of organisational development. And by an ethos of organisational development, I mean the notion that the best way of improving an organisation is by building on the intrinsic motivations of its staff, aligning their values and organisational values. And you see that in a lot of these initiatives and a lot of the approaches taken by organisations. A lot of the time it will work very well, but there are corners of the organisation, there are staff whose behaviour is persistently a cause for concern over time, there are fiefdoms and sort of little groups that continue to cause problems, where it becomes clear through time that this organisational development approach isn't sufficient. And so all of these approaches do need to be backed up by very rigorous, systematic, and again, well-administered disciplinary approaches where necessary. And that too takes huge amounts of time and effort. The third challenge is around caring for people who embrace openness, including staff, patients, and carers. Of course, there's lots of documented, really dreadful treatment of people who have blown the whistle and who have found themselves unable to be employed by NHS organisations again. At a much more mundane level, we also found lots of examples of people who had raised concerns in a more discreet way, in a gentle way, who had tried to do the right thing, who also found themselves on the receiving end of nasty consequences, ostracised, moved on, even receiving retaliation from their colleagues or from their managers. And again, past experiences of this have a real reverberate through time. It's very, very difficult once that kind of trust has been breached to restore it. True for patients as well as staff. So again, caring for people who do seek to speak up, not only at the time of raising concerns, but also afterwards, seems a really important priority. And then finally, I'd just like to say a few words about how patients and carers and families seem still to be quite marginal to this. There's been lots of policy efforts to support staff in speaking up, so freedom to speak up, guardians and the like. But for patients and carers, the avenues for raising concerns don't look so very different from how they looked before Francis, 10 or 15 years ago. And that perhaps is surprising, given that Francis himself was very clear on how carers, patients, families were crucial in raising concerns at Stafford. So Cure the NHS is the obvious example, but these people were really important in exposing problems in Stafford and in other places. Morecambe Bay springs to mind as well. And yet patients and carers are still positioned as beneficiaries of openness rather than active agents in it, at least at a national level. So there is no national equivalent to freedom to speak up for patients and carers. We did see some interesting examples of that kind of work at a local level. And I think there's something to be said for spreading that kind of learning, building on it elsewhere, and perhaps a need also for more coordinated national level action to try to benefit from the inputs that patients, carers, and families can make. Thank you very much for listening. That's it for me. I think we've got about 10 minutes or so for questions. And I just need to show you this acknowledgement and disclaimer that says that these are our views as researchers, not the views of our funder. Thank you very much.
Great, Graham, just unmuting myself. Really good food for thought, and obviously open for questions now, and interested in questions. I'm interested. There's a whole host of things in there of interest, and but one thing which I think has been a theme through our conference, and any conference these days, is the move from an organisational focus to a system focus. And I wondered whether you had any reflections. Clearly, that's not necessarily relevant to your to the work you've done so far, although some of the larger merged organisations may be relevant to this. Have you any thought about the opportunities and maybe threats for the progress we've made that lie in that transition?
Yeah, I mean, I think, so of course, when we were doing this research, the white paper hadn't come out, but of course, integrated care systems and ACOs were already a lot of the talk. I think what's interesting about the policies that we were looking at, which is partly because of when they were formulated, is that they are all directed at the organisational level. And a lot of these things remain, at least for now, organisational responsibilities rather than, ICS, for example, responsibilities. That, of course, in itself poses challenges because, as long as that accountability framework is structured the way it is, then people within an organisation are going to be looking in that direction in terms of what they do and who they're answerable to. I think, so, I don't know if there's that much detail yet on the regulatory framework for the white paper, assuming it does become law, but that clearly is going to be an important concern, whether it's at the secondary legislation phase or wherever else. I think you're right that it's very likely that a lot of the challenges that we identified at least repeat at the system level, possibly even become compounded at the system level in terms of that joining up of intelligence, for example, in terms of uniformity of approaches to disclosure, to investigation that bring together different parts of the system. If that's difficult within an organisation that at least nominally is part of the same body and has the same chief executive and so on, it's even harder when you move to the system level. But of course, yeah, a lot depends on how those systems are actually realised.
And just a sort of supplementary, do you have a nervousness that, any transition is about making sure you manage the handoff so you don't sort of lose during the transition, but are you a bit nervous that there'll sort of be a one-size-fits-all approach to this, which looks good on paper but actually misses some of the cultural change you're talking about in consequence?
I think it's a really challenging tension. So one of the organisations that we looked at as a case study had just come out of a merger, and it was now a very, very big acute trust. And it felt from speaking to people there, like for let's say the dominant part of that new organisation, it was business as usual, and for the other parts of the organisation, it was back to square one. So, there are perhaps reasons why the dominant organisation was dominant, and it may well have had some very good ideas around encouraging openness and systems for achieving that. But it did feel like for people elsewhere, they'd been putting together a lot of work that, had now come to nothing. They had to relearn systems, relearn approaches. People, on a personal level, people like the Freedom to Speak Up Guardian had contacts in one part of the organisation, but not others. So I think but on the other hand, there are also issues if you allow 1,000 flowers to bloom. And again, I suspect that plenty of people here have experience of that. So there's something to be said, and I don't have any answers here, but I do have sort of, prompts along these lines. There's something to be said for trying to collate organizational approaches, trying to work out what is the good from across a set of organizations that are coming together, making sure that it isn't just a matter of imposing something that is going to work in one setting on another, and instead trying to come up with something that works well, that shows people in different parts of organizations that their efforts to date are valued, and which brings together rather than reproducing organizational separations from the past.
Yeah. Okay. The NHS is each element of the NHS, as well as the NHS as a whole, is an incredibly diverse organisation in terms of its the background of its staff, whether it be any element of a diversity. Obviously, this year we've been particularly anxious about wanting to reflect Black and ethnic minority diversity, but it's true of all sorts of other diversity as well, and it's true of professional groups and staff groups. Did you track any concerns or diverse responses to all of this in that environment? So doctors were different to nurses. That Black and ethnic minority staff are more concerned than general staff, which sometimes comes out in surveys, for example.
Not in a systematic way. I mean, without going into too much methodological detail, we were very keen to make this open, particularly in the case studies. We're very keen to make this open to people and to overcome any hesitancy they might have to talk about, they might have in talking to us. So, for example, we didn't take written consent, we didn't collect demographic details and the like, just to ensure that people felt that they could speak openly with us. So I couldn't comment systematically on that. I mean, certainly, as you say, wider evidence suggests, for example, that Black and minority ethnic doctors, for example, are more likely to be investigated by the GMC, and there seems, it's not just a matter of referral investigations. There also seem to be issues in terms of the outcomes there, and it could well be that racism is implicated in that. We certainly heard anecdotally, and again, it reflects received wisdom and perhaps some evidence, that doctors versus nurses versus allied health professionals versus managers have different approaches to this. Probably the most prominent thing that we heard persistently, and again, I'm slightly hesitant to put too much credibility in this because of the nature of the research and what it can and can't show, but it was certainly a persistent message, was a generational one. So there was a sense that more recently trained healthcare professionals and managers were more likely to see the importance of openness with patients in particular, were more likely to be keen to open up conversations within teams on a more mundane level, were less skeptical, I suppose, about things like instant investigations, duty of candor, the balance between blame and learning. There's two ways of looking at that, of course. On the one hand, you could say that it is a generational difference, perhaps. On the other hand, it's just that they haven't had the chance to become frustrated and battered down by the system. So you could look at that in a more positive way and a more negative way. I wouldn't overstate it, but it was a persistent feature from a lot of the people that we surveyed and spoke to.
Okay, it may just be idealism, the idealism of youth, or it might be people understanding some of the dilemmas that are faced in this as they get.
Or training. I mean, I think is the other key point there, that patient safety, interpersonal behaviour are bigger parts of the curriculum now, formally and informally. Okay.
Significant number of people who are joining this conference this week will be non-executive directors, and indeed some will be governors in Foundation Trust. Have you got any view about how those colleagues who are essentially one step removed from the day-to-day can be really useful in this agenda?
I think, I think where that partly comes down to the sort of the official, kind of documented role of NEDs in terms of challenge and accountability and so on. So I think that's really crucial. I think one way of perhaps enacting that role is in relation to interrogating data that's presented at boards and also asking questions about what's not there. So I suppose coming back to one of my points around functional administration, but also coordination between different units, bringing together different sources of intelligence. The organisations that seem to have got that pretty well done, really spoke highly of the importance of collating synthesizing different forms of intelligence about what was going on, be that, routine data, be it gossip, be it incidents, be it freedom to speak up Guardian reports and all the rest of it. So I think there's a lot of value to be derived essentially from interrogating that kind of data. And I suspect that that's where a lot of NEDs, particularly ones from relevant professional backgrounds, including outside healthcare, could have a really helpful role in processing, making sense of that data, and asking challenging questions where that data isn't present or where they think that the analysis could be more robust.
And sort of related to that, there's always this dilemma about how much you use the information, the facts that come from data, and how much you use anecdotes by walking around and talking to individuals and everything else. What's your feeling about the balance there between generalizing from the particular as distinct from actually looking at something more systematic?
So I think both are absolutely vital. Each source of knowledge has its advantages and each has its limitations. And I think the real benefits to be derived from trying to combine the two. And, it's very easy for me to say that. I know that this means an awful lot of labor apart from anything else, particularly in terms of trying to, whether it's leadership walk rounds or whether it's chats in the corridor, or whatever else, whether it's informal conversations with freedom to speak up Guardians. It's hugely time consuming, perhaps more time consuming, frankly, than collating, if you want to call them hard data, hard knowledge about what's going on. But both of them, I think, will help you to get a real picture of what's happening. In particular, again, thinking of some of the things that people told us in the course of the research, it's where there's either deficits in the data, absences, or apparent and sustained reduced quality in some of the data, whether that's around outcomes or process or whatever else, that can prompt the more informal problem sensing work that's needed to follow that. So it might be that unit over there seems to have outcomes that are problematic, or it might be that unit over there, there's always grumbles about it, or there's a silence, we just don't know that much about what's going on. So clearly, you couldn't rely purely on the anecdote, on the soft intelligence. You would be very foolhardy to put too much stock in that. But it can help alongside harder forms of knowledge to really form a full picture about the how and the why.
So it's part of that triangulation process you were describing, really.
Yeah, absolutely.
Regulators, you touched on this, and obviously CQC inevitably comes into this territory in their expanded responsibility since Francis. But do you have a view as to whether you might be sensitive about how you want to answer this? But do you have a view as to how well regulators have handled this in terms of the danger of there's an obvious danger which you refer to yourself of talking the talk but not walking the walk, if you like, around long-term cultural change and how fragile it is?
Yeah, I think so. In terms of the changes to the CQC, for example, we had a lot of positive feedback from the senior stakeholder interviews that we had in terms of the CQC being local sort of regional officers having a much more enduring long-term set of conversations with healthcare providers, rather than it being a matter of periodic panic in response to inspections. So there was much that was positive about the sort of the changes to the CQC, in part in response to Francis. I think, and I haven't watched Panorama yet, but I plan to from last night, I think it was. What strikes me from what I've read about that investigation is that a lot of the things that we've spoken about, or I've spoken about today at the organisational level, potentially apply at the system level as well, or the regulatory level as well. And I'm thinking, in particular here about having good systems in place to gather up intelligence and to disseminate it appropriately. So, the stuff around externally commissioned reports from Royal Colleges or whoever else. The fact that the CQC doesn't currently seem to have a way of collating those, isn't aware of them a lot of the time because organisations aren't obliged to tell the CQC or monitor, or disseminating the information. These are not easy. It sounds really, really easy, doesn't it, to have a list of reports and then to let people know about them. In practice, we all know that these administrative systems, making them work properly and slickly and responsively and adaptively, is a huge task. But I think it's a task for the regulatory bodies as well as individual NHS provider trusts.
Yeah, I was very taken by your very last point about the marginality of patient carers and families, which I think will strike a chord with a number of people that will find it difficult to get the resonance and traction that we would ideally have in that space. Did you find any really good practice anywhere? Somewhere that people should pick up this as an example of how you can make this really relevant to the whole field?
Yeah, so something that we did do, and I haven't actually included a link to this in the resource area, but I can do that. We put together as a sort of an appendix to our lengthy final report to the Department of Health and Social Care, an appendix of some examples of good practice, some of them from our research, some of the things we'd heard from people talking about good practice elsewhere. The details of those are going to fail me off the top of my head, but certainly one of them was along the lines of a kind of an equivalent role to freedom to speak up. For patients and carers, and trying to publicise that. Obviously, that's a very different task from the wider public versus an internal organisation. But there was stuff around that. The role of PALS as well was also highlighted as quite important. And again, my sense is that patient advice and liaison services operate quite differently in different places. Some are much more proactive, some rather less so. But again, a potential link in the chain in terms of not just concerns, but not just advice and liaison, but also concerns, and ensuring that those are fed into the system appropriately. Likewise, health watch organisations, very varied indeed in their operation from place to place. I'm involved in another study at the moment that's looking at that, but some of them, much closer kind of intelligence sharing relationships with the organisations they work with than others.
Yeah. Okay, it might be interesting if you could include that in the resource pack, actually, correct?
I will do. Yes, I will send the link to the organisers.
Final question, because this is good stuff. We could spend the rest of the day discussing this. It's really important. I asked a couple of our earlier speakers this, but because we are at one of those key points at the moment where not only do we have major change in the NHS and organisationally, but we also have those rare opportunities where there's a new chief executive likely to be appointed in the next few months. In this particular space, rather more generally, what would you want that new chief executive to be focusing on to be most effective?
That's a great question. I think part of it relates to something we were talking about earlier on around how to scale up or scale out these kinds of things to integrated care systems. I think a lot of it is going to be about, just making the current systems work. And, this isn't exactly a top-down reorganisation of the NHS in the way that some others have been in the past, but it does create, ripples, and it can be hugely time-consuming. So I think there's a big piece of work to be done there around ensuring that what we've already got works as effectively as it can, in practice. I think one other thing that I'd emphasise is that our research did focus purely on provider end of the NHS, not including GPs or CCGs. And clearly there's, a lot of this is relevant to GPs as well. So if we are looking at integrated care systems as the way of the future, then again, I suppose picking up on the point earlier on, we need to find ways to make sure that we have systems that work for all parts of the NHS, all different providers, primary care, community care, secondary care, tertiary care. And there, as you said, there probably is an opportunity here to make these things coordinate and work better together than they have in the past.
Yeah, great. Thank you, Graham. I mean, that's been a really great session, really interesting stuff. And I think people will want to reflect on it. And I suspect they'll want to go back and listen to the on the website to pick up on things they've missed. So thank you, and all power to your elbow going forward in this space.
Thank you. Well, my Twitter and my email address are on the slide, so I'll be delighted to hear any feedback.